So it is a LAAO or left atrial appendage occlusion tips and tricks. So on the background, this was first performed in 2001 with plateau device, because in non-valvular AF it was found by this landmark study by Blackshear and Odell, who reviewed 23 papers involving 1400 patients, and they found that in non-valvular AF 90% of cases LA was involved, and in valvular AF around 57% was involved. Curiously, the involvement of left atrial appendage in clots and thereby thrombogenicity in rheumatic heart disease is not as high as we think to be. This importance is amplified by recognition of AF-associated left atrial dysfunction. These days, we are actually evaluating the function, dynamics, and other features of left atrial appendage. Oral anticoagulant decreases stroke by 64%, disadvantage being bleeding, etc. You can go for occlusion and surgical ways. At one point of time when rheumatic valve surgery was very common, they used to ligate all the appendages. But later on, it was found in paper from Annals of Thoracic Surgery that it might not be so much beneficial. Well, to put my matter into perspective, I'll discuss a case. This is a 74-year-old female. She was having multiple risk factor, was on rivaroxaban, and she bled. She attended with ADHF, accelerated AF rhythm, and severe metabolic acidosis. She was on cardiogenic shock, hemoglobin of 5.4, resuscitated. This was the presentation ECG. And on echo, the LV function was normal, LA was dilated. She needed ventilation initially, 4 units of Paxil. There was some renal involvement, and hence urgent endoscopy was done. Endoscopy showed enteral gastritis and a bleed from the GI thing. So sclerosing therapy was done. After 4 blood transfusion, conservative treatment, on ventilator she improved. RFT was 1.7 on the 7th day. AF rate controlled to 110 per minute. Now she was on rivaroxaban. We had to take off, and we put her on half dose of low molecular heparin to mitigate the stroke risk. However, you must be seeing that she was on very high chargeback score. So with an idea that how to manage it, we thought that we'll go for a device closure, and hence the evaluation started. This is the T showing a nice and clear LA appendage. Meanwhile, she improved, and we took her out, LA appendage closure. So after the septal puncture, we located the right upper pulmonary vein, left upper pulmonary vein, anchored up with a stiff wire, took the sheath. Now the important part is the septal puncture has to be inferior and posterior. This is very important, because if we do the usual septal puncture, then the maneuverability of the sheath and the device will be problematic. The second part is because there is a propensity to cause perforation and tamponade. So the use of pigtail is a must. With the use of pigtail over a sheath, we actually protect the tip of the sheath from injuring the LA, this thing. So from the left upper pulmonary vein, we gradually come down and engage the left atrial appendage. Here we see it is nicely engaged. And then comes the, there is of course ongoing TE guidance, and then comes the device. This is a 24 size device, Watchman device. We had put the device with the placement. I am coming to the placements and other nitty-gritties later on. With appropriate placement and multiple views, we proceed to deployment of the device. So here the device is nicely deployed. So post-procedure, initially DAPT was given, aspirin clopidogrel, as per as mandated guidelines. On the second day of the procedure, she had breathlessness. There was pleural effusion. Somebody tried tapping. It was a junior guy, and resulting in hydropneumothorax, required an ICD. However, short period of ventilation, and gradually she improved. So on the 7th day of discharge, weakness was there. She was on wheelchair. Hemoglobin was 10.8. TE was done, and we saw that there was no peri-device leak, but the flow was reduced by around 30%. On the 21st day, the patient came walking. Minimal flow across the device, hemoglobin had improved to 11. So we had planned for usual follow-up, and on the last follow-up last month, this was the T. You can see the device nicely tucked. This is 135 degree, slightly modified. She's a thin, frail lady. The device sitting over there, there were no peri-device leak, and other features was okay. Yes, the device had, from the period of implantation, slightly gone inside the LAA. Well, let us see now what the left atrial appendage has in store for us. This was a traditional view that we have 4 types of appendage: chicken wing, windsock, cactus, and cauliflower. So we use generally to view it, either we can use an echo, we can use a CT or an MR, and it involved 4 views: frontal view, left lateral view, upper 45 degree view, that is a CT, and upper 90 degree view. However, only with this plain concept, it is not possible to understand the importance of left atrial appendage. So then comes the Butler-Lawley naming system, published in World Journal of Cardiovascular Surgery in 2014. They very elegantly described 4 or 5 patterns. The hook was an arc structure that is symmetrical at its midpoint. So this is the hook. The seahorse has an appearance of an aquatic animal. Seahorse, you know, sea anemone or seahorse. Then comes this is the seahorse, nice looking shape. Then comes the finger with a protruded thing. Then you have the knob-like structure. It is like your knuckle. This is the wing, something like a Japanese fan. And the spiral, where what you see in temple architecture. This is the flame, irregular structure, and the arrowhead. So this was all possible because of CT scan. On this paper further, they also describe in basis of this that there can be multiple morphologies. There can be wing and hook, there can be double wing, there can be double wing and hook, and finger, wing, hook, knob, all kind of permutation combination is possible. So with this, the controversy was always there, how to adequately, universally define the left atrial appendage. So this new classification system came. 3 letters were suggested. First position was in relationship of ostia and the depth of the appendage. Second position was the number of the lobes, and third position was deeper and useful lobe. A means depth is more than double the ostia diameter, like B is depth less than double the ostia diameter, and C is depth greater than the ostia diameter. So you take the ostia diameter at the junction of, the left atrial appendage, the left atria and the appendage. You don't take these oblique measurements, you take the straight measurements, right? And the depth is not the perpendicular line, but at the most distal point, you see the depth from this line. So based on this, if we say A2I means that depth is more than double the ostia diameter. There are two lobes, 2 means 2, and third position is inferior lobe. The inferior lobe is more prominent. So when you land the device, you land the device on the inferior lobe. So these are the various devices available. The Watchman, ACP, Amulet, Plateau is of historical importance, the Ultrasil, Lariat, and out of all these devices, only 3 devices are in vogue now. This is the Watchman and the St. Jude medical device and the Lariat. Lariat is more discussed than practically done. Yes, in India, practically the other device, which is the Lambre device, which is by the LifeTech company, are in vogue, and we do some cases with that. This is the Watchman device, and in the 3 device, mostly they are endocardial, but Lariat device needs epicardial approach. Only FDA approved device is the Watchman device. The Watchman device received FDA approval on basis of randomized controlled trials. 2 randomized controlled trials were very important. That is the Protect-AF and Prevail. Together they have more than 700 patients, and they showed that they were done all in high charge by score, and peri-procedural they had been continued on warfarin for 45 days and discontinued, followed by aspirin and clopidogrel for 6 months. All of these trials. Even the registry and the non-randomized data like the Evolution and UK registry also had this thing. They showed some bleeding propensities. In the randomized control trial, Protect-AF, the sheath size was big, 16F, so the bleeding was more. It came down to 12 and 14F, so bleeding decreased. Device embolization was minimal, and procedure-related stroke was also minimal. So this was the other device which is there, which is the ACP device or Amplizer cardiac plug, or the Amulet it is probably called. It doesn't have any randomized control trial, but based on the available data, we can see the efficacy and the profile. The side effect profile is similar to the Watchman device. These are the data for Lariat device. Again, it doesn't have any randomized control trials, but then Lucky Reddy et al., Price et al., and all they have studied. Number of population was less. Lucky Reddy had been an active promoter of this device. And this device, although looks very elegant, concept looks very elegant, is difficult to manage. So Watchman device has been there since 2002, FDA approved in 2015. Deployment is by pass criteria. Pass criteria means position is determined by device that is just distal to the LA ostia. Anchor we have to see by stability by tuck test. Tuck test means we have to pull and see. The size device is compressed by at least 10 to 30%, and seal, compressed coverage of all lobes and no residual leak more than 5 millimeter. This is the Amulet device. Amulet device for deployment, we have the close criteria. Important features are we have to create a ball-like structure so that the ball means the diameter should be twice the diameter of the sheath, and the important difference between the Amulet device and the Watchman devices, you have to give a counterclockwise tug. When you give the counterclockwise tug, it sits into the more prominent lobe of the LAA. Then this is called the Lambre device. The main thing is it has an umbrella-like structure. Lambre means in left atria there is an umbrella. So it has got an umbrella-like structure and a side disc. The disc actually seals the ostia. We can position the delivery system in LA, and the deployment of umbrella whole system is pushed forward for stabilizing by 8 hooks. In the trabeculae, you give a light pull, cover deployment in ostia, light push, and final tuck test. It is feasible for all types of LA. So procedural consideration, transeptal puncture, I told you it should be inferior posterior. However, TE has some blind spots, but when we use CT, there is no blind spots. Procedural time, fluoro time, and total contrast is quite favorable. Patterns of leak, you have generally the peri-device leak to be seen, depends on jets, number of jets and Nike's limit, less than 1 being non-significant, 2 to 3 is mild, 4 to 5 millimeter moderate, more than 5 millimeter severe. It is only when the peri-device leak is severe we need to be worried. You have to also to finely differentiate between the contrast permeation and leak. Contrast permeation means some flow of dye through the membrane of the device, whereas peri-device leak means either on the superior aspect or the inferior aspect there is a leak. Patterns of the leak by CT, you can see peri-device leak, intra-device leak, missed leak, means you cannot find the exact source. In that cases, you have to use some special algorithm to see. There is something called PAVL or patent appendage and visible leak. PANVL means patent appendage is there and non-visible leak and non-patent appendage. The most favorable thing would be non-patent appendage. Nowadays, it is a fashion, especially in the West, to report it in Hounsfield unit. They compare the contrast density in the left atria and the contrast density in the left atrial appendage to quantify numerically the number of, the amount of jets or amount of dye going in or out of the LA. And they typically give reports in terms of 100 or 150 or 110 Hounsfield units. Complications, adverse complications are generally less, 3.3 with Watchman, 3.2 with amulet. Embolization rates are minimal. Pericardial effusion, although it is a contrast but with adequate care, with the use of pigtail, very gentle procedure, this can be avoided. Bleeds have largely come down because with sheaths becoming smaller, especially with Lambre or the LifeTech device, you can use only 10F sheaths. So 10F sheath is almost like an angioplasty. So that too in the venous system. So that is not a problem at all. However, Watchman requires still 14 French sheaths. Areas of uncertainty remains. Where are the areas where the discussion needed? Whether LV dysfunction patients should be taken or not. Advanced LV dysfunction patients were not studied in all the randomized controlled trials. And the duration of antiplatelets. Right now on the basis of 2 trials, we are giving antiplatelets for at least 5 to 6 months. And the timing and duration, whether single antiplatelet should be carried or not. Thank you.